Bonjour à tous, merci Cash et merci Bob pour ce très joli témoignage. Donc j'ai le plaisir de vous présenter là, le premier speaker qui arrive directement de Paris, donc le professeur Joe-Elie Salem, qui est clinicien-chercheur, MD, PhD, qui a fait ses études à Paris-Sorbonne et maintenant qui est en charge du centre immunocardio à la Pitié-Salpêtrière. For those who know me, I like sports, so I like stats. So let me tell you Dr. Salem's stats, or more than 250 publications, more than 20,000 citations. But more importantly, and thanks to him and his paper, the way we treat myocarditis, at least at the CHUM, has changed because we don't give Solumedrol high dose alone or anymore. And he will tell us why we should or should not give only Solumedrol in the context of myocarditis. Donc, merci beaucoup.
So, thank you very much for the, merci beaucoup pour l'invitation. Donc, en effet, je viens de Paris. Je suis très ravi de venir vous présenter ce sujet-là. Et si vous avez des questions, n'hésitez pas à m'interrompre. So, I'll switch to English, I guess. Just 1 second to know how this works. Just where should I? It's very weird. Sorry. It's not. Is there any mouse or something? Looks good. Thanks. So yeah, I will be speaking to you about myocarditis. Indeed, I don't like to call it anymore myocarditis, but more myotoxicity, because you'll understand that this disease is not just basically targeting the heart, but mostly all the cardiomuscular organs at the same time. So here are my conflicts of interest, and the most relevant one is I have a bunch of patents related to the treatment management of this disease. What are the main cardiovascular toxicities? So when ICI started, as was just described by Bob just before, it was basically 10 years ago when we were started looking at what would potentially be associated as adverse events with this new class of drugs. So the first work we have done was looking at the different cardiovascular toxicities, clustering them by the different organs and systems, and conditions, and looking which kind of diseases were associated with immune checkpoint inhibitor, which adverse event would be associated with immune checkpoint inhibitor as compared to the controls. And basically what popped up was very logical. All the itis were popping up. So basically all the inflammatory disease of the heart and the different cardiovascular tissues. So myocarditis, pericarditis, and vasculitis. You don't care much about the stats, but basically the one in bold are the ones statistically significant. And the first thing we wanted to check, is there any over-reporting? Is it more associated with combination of immune checkpoint inhibitor, and which type of itis is more associated with PD-1 or CTLA-4 blockade? And as you can see here, myocarditis was more associated with anti-PD-1 rather than anti-CTLA-4 drugs, and more importantly, combination of anti-PD-1 plus anti-CTLA-4 would be associated with an over-reporting even more. So combination therapy would be potentially a tentative risk factor here. And for pericarditis, it was also anti-PD-1, and temporal arthritis, it was more a CTLA-4-driven disease. So another question we had is those different tissues, cardiovascular tissues, would be overlapping, because us in cardiology, in the world of the cardiology, we would often call it myopericarditis. But one thing which was striking here, instead of having 60%, 50% overlap between myocarditis and vasculitis and pericarditis, we just had a very minimal overlap. Why? Because basically now we know that the antigens that are in the myocardium and the one in the pericardium are not the same. So the autoreactive T cells that we do have in our blood that will be reactivated by immune checkpoint inhibitor will basically flag and track specific antigens that are not shared between the different tissues, those different tissues. So myocarditis, pericarditis, and vasculitis are not overlapping because of the pathophysiology behind it. Another important learning is that those diseases and conditions will happen very quickly, very early on, after a few doses. So basically, most myocarditis will happen in the first 3 months of initiation because you have or you don't have this autoreactive T cell at the time when you start the ICI. If you have it, it will get activated 1 week, 2 weeks, the T cell will get ready to go and then start killing the organs, which make it clinically happening basically around a month after starting ICI. You have or you don't have this autoreactive T cell. What was the incidence? So initially in the first trial, oncologists leading this trial were not looking into the specific conditions, so incidence rates were extremely low. Monotherapy of anti-PD-1, nivolumab 0.6 percentage incidence, on combination therapy 0.27, and in the first real-life cohorts where people were paying a bit more attention to it, the incidence rate was around 1.14%. So the incidence rate were spanning between 0.3 to 1%, 1.5%. This recent meta-analysis of clinical trial was further flagging this around 0.3% in terms of incidence. So we're roughly in this incidence rate. So nowadays, what are the main bioclinical feature and outcome of ICI myocarditis? Initially, in the first paper I showed you, in the pharmacovigilance paper, where we looked worldwide at the different myocarditis cases, the mortality, the fatality rate was around 60%. So this was back in 2018 on 100 patients. Nowadays, we have put together this international registry collecting cases worldwide. In this iteration of the data set, we had 750 cases from 17 countries and around 120 institutions, and those are the more contemporary data with this. So you can see that the fatality rate are around 17% at 1 month, and that the burden of the cardiovascular MACE, major cardiovascular events, is around 1/3. So now that we're managing more accurately and we're detecting more smoldering cases, the numbers are less dramatic than before. But again, in this iteration of this registry, the time to onset was around a month, as you can see here. And the main cause of death would be life-threatening arrhythmias, heart failure, and this one is very important because it took us some time to identify respiratory muscle failure. So why a myocarditis would be associated with respiratory muscle failure? Because of this same story I was just tagging, autoreactive T cell recognizing antigen shared between the myocardium and the other muscles. And when you start getting your diaphragm and your respiratory muscle killed, then you're in trouble and you start having hypercapnia. So a lot of the patients initially where we were just focusing on the heart, we were able to manage the heart, and then we get them basically for the first one dead in the morning with capnia around 120. And when we went to autopsy, we were seeing that it's not the heart the problem anymore, but it's respiratory muscle failure. So that's why I don't like to call it anymore myocarditis, but more myotoxicity, because it will involve, in overwhelmingly all cases, virtually all cases, some part of systemic myositis that will pick its choice between the heart more, respiratory muscle more, or everything at the same time. So in terms of how we diagnose, troponin is extremely sensitive, preferentially troponin T. I will show you some more data afterward to explain that. So virtually, if troponin T is negative, you can exclude the diagnosis, but if a troponin T is positive, it's the first step to establish the diagnosis. Less than 5% of positive troponin in cancer patients will be eventually myocarditis, so it's just the starting point. For troponin I, there are some tricks with it, and it can be negative up to 10 to 15% of the patient, depending on when in the story we capture it. I'll explain more afterwards. So troponin T is super sensitive. Troponin I is at the start of the disease, but it can negate early on. So you have to be paying attention to this detail. In terms of, again, it's a myotoxicity, so all the other biomarkers of the muscle, including creatine kinase, will be up. So that's why here, virtually in this red cap, 70% had positive CK concomitantly for positive troponin. But you have to keep in mind that as soon as you start steroids, CK will become negative very early on, independently of the evolution. So a negative CK after steroid start is not anymore interpretable. So in terms of LVEF ejection fraction, it's often normal, so you cannot rule out or do much with the LVEF, knowing that in patients with cancer, also a lot of them may have pre-existing left ventricular function that is not ideal. So it's one element, but it's more for stratification. Cardiac MRI in cardiology world was supposed to be the gold standard for the myocarditis stuff, but in this disease it's not working well. Up to 1/3, even half of the patient may have a normal cardiac MRI. So you cannot rely on a cardiac MRI to tell you exactly if it's a myocarditis or not. It's just one added element that you have to integrate to the whole biomarker, ECG, pathology, eventually story. So ECG in this iteration was of the international registry was also very sensitive with a lot of abnormalities that you can identify on the ECG, and particularly microvoltage, QRS microvoltage. So that's why it's very important to have an ECG before starting ICI, so you can look when you're going to have this suspicion if there is any changes, and particularly in the QRS voltage. So ECG, echo, MRI, biomarkers, troponin, and CK are keys that you have to integrate to be able to tease out if it's or not the diagnosis. And the last two pieces are very important, is clinical. Again, most of these patients will have, if you pay attention to it, some form of concurrent myotoxicity, including myositis sign, and what some people would call myasthenia gravis, which is not, but it's myositis affecting the different muscles, including the muscle of the eyes. So you will have diplopia, ptosis, dysphagia, dysphonia, and all those symptoms are related to basically also a myositis of these different organs. So having a patient coming in with a troponin positive, an ECG modified plus diplopia 3 weeks after ICI start, it's a myotoxicity diagnosis. And lastly, you can use also pathology. So cardiac pathology, endomyocardial biopsy is useful, but again, this disease is very patchy. That's why MRI is also being tricked. So there may be sampling error where you're going to pick 2-3 pieces, but not at the right place. So they may be negative. So in this registry, 2/3 were positive and 1/3 was negative. In terms of pathobiology, what you will find on those biopsies would be those dots, which are basically lymphocytes and macrophages, coming in and recognizing the muscle and destroying them. So the pathology main feature will be infiltration of the myocardium and the peripheral muscle with T cell and macrophages leading to their own death. And again, why the muscle and the myocardium? Because of the story of probable autoreactive T cell recognizing shared antigens in these organs that will be activated by ICI. So one tentative antigen may be alpha-myosin. It has been identified in mice models, so we don't know yet in human, but it's one possible antigen. So in our hands, in the first 40 consecutive patients that we have seen for myocarditis, sent for myocarditis, initially we were not doing endomyocardial biopsy, so we went on peripheral muscle biopsy because the pieces you get are way bigger than endomyocardial pieces. So on this peripheral muscle piece, you can imagine that the black square is basically the size of what you would get endomyocardial biopsy. So you can see that some spots are normal, looks normal, others are not. So depending on the sampling bias, that's why you can get normal, falsely normal biopsy. So on the peripheral muscle biopsy, you will see the same exact features, lymphocyte, macrophages, infiltration, destroying muscle. On those 40 consecutive patients coming in for myocarditis, peripheral muscle was abnormal and confirming the diagnosis in around 90-95% of the patient. They were sent for myocarditis, but when you look at the peripheral muscle, they were almost all positive for it. As compared to endomyocardial pathology, which was suggestive only and definite in around 2/3 of them. So again, the sampling bias, and we were doing 3 to 4 samples. And to further support this concept of myotoxicity, here we queried again the International Pharmacovigilance Database, looking at all the different IRAE, so colitis, diabetes, enterocolitis, all the different IRAE. And the only one to very hardly cluster are myasthenia gravis-like myocarditis and myositis. So again, supporting the concept that there is something that is super common about those three, which now I call myotoxicity. If you look at it the other way around, and we looked at our EHR, big EHR here, there were 3 million patients in it. It's one of the Parisian multiple hospital EHR system shared. And we looked at the one coming in for theoretically myositis and myasthenia gravis. And looking the other way around, we were able to identify that 86% of them had very likely myocarditis concomitantly. And when we looked specifically at the muscle explaining potentially the myasthenia gravis-like phenotype, including diplopia, ptosis, you can see that, oh, sorry, can you please do something? Yeah. So the muscle, lateral rectus muscle, deltoid muscle, and diaphragm were all having the exact same features, with lymphocyte and macrophages invading those muscles, destroying them, and leading to the different clinical phenotype. So this has like therapeutical impact, because if you have a myositis that is T-cell and macrophage driven, it's not the same thing as having those acetylcholine receptor autoantibodies that you may want to target with IgIV or plasmapheresis. So in all those cases, CK was up, creatine kinase was up, which is not common for the idiopathic myasthenia gravis. All the patients with muscle pathology had myositis. On electromyogram study, almost none had decrement, only one, which is a feature for idiopathic myasthenia gravis. And this only one was basically having myasthenia gravis as past medical history before starting ICI. And in terms of acetylcholine receptor autoantibody, 1/4 was positive, and we'll come back to this point later, probably pre-existing ICI start and flagging some thymic disimmunity. In terms of biomarker, so those are the one we can play around: troponin T, troponin I, ALT, AST, CK. ALT and AST are not liver specific, they're also expressed in the muscles. That's why when in this cohort, Michigan cohort led by Salim Hayek, and we helped adding our cases, definite cases, they were looking prospectively in 2,400 patients approximately for ALT, AST, LDH, and CK prospectively. And for the patient having positive CK, they were further going into troponin T in this cohort. And by combining our cases and their cases in this setting, we were able to identify that to have a definite ICI myocarditis, you needed to have at least 3 of those biomarkers concomitantly up, so AST, ALT, CK, all up, on top of troponin. And if you had only troponin increase or troponin increase without at least 3 of those biomarkers up, your chances of having a real myocarditis was not high, 5%. Versus 95%. So this is super helpful. When you have a suspicion of myocarditis because you have a troponin positive, and there are many diagnosis alternative mimics for positive troponin in this setting, look at AST, ALT as compared to baseline, and CK before starting steroids. It can help you to further stratify the diagnostic probability. And when we look on the right side, I don't see here, okay. When you look at the right side, you can see in yellow it's troponin T, in blue it's troponin I, and in gray it's CK. You can see the trend and the evolution of this biomarker for 1 year after admission. Troponin T stays up forever. Virtually, they're all positive and they stay positive even 1 year after the diagnosis. CK, as you can see, half of them within 7 days will be negative. They will probably, most of them will be positive starting like initially. You have to, in this cohort, some patients receive steroids before coming to us, so maybe explaining some part of the CK negative. But as soon as you start steroid, it's gone, become negative. In a week or two, you have nothing left for CK. Troponin I will follow a similar trend. That's why you may be tricked sometimes when you're capturing the patient a bit late as compared to the initial process. You will get a negative troponin I, but a still positive troponin T. So this difference between troponin T and I is very useful because in cardiology there are not much diseases where both troponin are not following the exact same trend. So this difference in the trends is also helpful for the diagnosis if you closely monitor it for a week or two. And this difference would be maximal 2 to 3 weeks after the start of the presentation. So this discrepancy between abnormality in troponin T and I is maximal 2 weeks after initial presentation. And here we looked at which one carried the most prognostic value. So this paper, we had a bit of trouble to get it in finally because one of the reviewers didn't like that troponin I was not as good, but you can imagine here, it's not here anymore because we had to take it out, but it will be exactly the same color of the CK. So basically troponin T has a higher prognostic value than CK and troponin I. And you can see at the time of the major cardiovascular events, troponin T is always positive as compared to troponin I and CK, which can be negative. And in our hands, this cohort was bicentric, us and a German cohort, Lawrence Lehman. In our hands, in both centers, we're using troponin T in our prospective cohort with a cutoff of 32 times upper reference limit. Below this cutoff, myocarditis were not severe, and above this cutoff, they were pretty severe with 75% having MACE. So which translate into 14 the upper reference limit is 14, so it's around 420, which is the cutoff we're using currently. But you need to have a troponin T. There is only one kit nowadays in Western countries. It's a Roche kit 14. So you need to make sure that you have the exact same kit because there are variabilities in the kit. ECG. ECG is also very helpful. You can see here this patient, the Thymoma patient, 25 years old patient before ICI and on admission for ICI, how the QRS in the most extreme patient, this patient went into cardiogenic shock afterwards, how it changed. You can see that the QRS is completely altered with voltage decreasing, QRS widening. So this is the most extreme changes you will see in this disease. In a very precursor iteration of the international registry, we had maybe 100 cases at that time, 150. We had 50 of them who had ECG before and after ICI start, and we were able to identify that many of the myocarditis, back then they were the most severe one, would have conduction disorder appearing, tachycardia, repolarization abnormality, ventricular hyperexcitability. So ECG is also very useful. That's why I really advocate for having an ECG before starting ICI, because it's going to be a very important reference if you have later on any diagnostic doubt. And in this first patient, also biased towards the more severe one, 25 to 30% of them had ventricular tachycardia and or complete AV blocks. And when you have complete AV block or ventricular tachycardia, back then it was a very bad sign with a very high risk of mortality. As you can see, 60% were dying within a month. Cardiac MRI. So again, in the cardiology world, before this myocarditis, ICI myocarditis emerged, most people would say that myocarditis is not possible if you have a normal MRI, but now we completely know that it is not the case for ICI myocarditis. And in this, one major feature for MRI to diagnose myocarditis is those white spots that you can see with the arrows here, the white arrows, and those are late gadolinium enhancements, we call it this way. So late gadolinium enhancement would mean that the late gadolinium is trapped in those sections of the heart and will stay there because they're dying. So this is a feature that is pathognomonic for myocarditis, viral myocarditis. And you can see here in this International Registry 100 case retrospective analysis that if you do the MRI within the first 4 days of presentation, only 25% of the patient will have this feature. If you repeat it later on, 75% of the patient will have this feature, and that this feature is not prognostic. So you can see that MRI is probably sensitive to time when you do it, and it's probably not as perfect as in other form of myocarditis. So the cardiac MRI people will say, okay, let's go beyond the LGE identification, which is a binary qualitative feature, and let's go for mapping value, like identifying the T1 and T2 properties of the heart. And this prospective small cohort, 21 patients, but was able to show 3 things that are important. First of all, before starting ICI, a third have LGE. So you have those MRIs that are negative with the patient being a patient, a real patient, and you have, before starting ICI, a third of the patient qualifying for one main feature of what would call afterwards a myocarditis, so also false positive. And T1 and T2 mapping, which are going to be the last line and third to last line, just by the fact that you're on ICI, will just change. 972 to 1026 significant, T2 54 to 58 significant. So the mapping value, the normal mapping values are also going to be tricked by the fact that you're on ICI. So that's why probably MRI can be improved and its performance can be improved, but if you use the norm and standard that we have used to identify viral myocarditis, which is basically a disease of a 40-year-old male, it's not gonna work for 75 plus cancer patient with multiple comorbidities. PET-FDG also was not very strikingly interesting, so it's our own cohort. A few years ago, we had at that time 60 patients suspected, half were confirmed, half were not, and in a nutshell, only 10% of the PET cardiac FDG were positive both sides, so none different between cases refuted and cases confirmed, and very low sensitivity. So that's why we didn't push very much more afterwards. So if I have to summarize, a patient coming on ICI with symptoms, so which I did not say before, it's nowadays we're identifying more and more patients without symptoms that have like basically very early on starting diseases or smoldering diseases. So this applies for a patient with symptoms. If you have a time from ICI start below 60 days, abnormal concomitant CK, stably elevated or rising cardiac troponin T, it's very likely a myocarditis. So you should stratify the risk and manage accordingly. If the time to onset is over 60 days, that CK are normal before starting corticosteroids, and that the cardiac troponin T is normalizing alone very quickly, it's very unlikely that it is a myocarditis. You should take your time, make sure of the diagnosis, probably avoid immunosuppression, and look for differentials. In terms of management and treatment, so the first iteration of the International Pharmacovigilance Database worldwide were showing mortalities, as you can see here, around 40, 50, 60%, which was not very nice. So very early on, the study on the right, which I have to say I was not able at all to replicate at all, so I don't know how those curves are possible, but this is what is published. We're saying that if you treat with 1 gram everyone below, like within 24 hours, everyone is saved, blue curves. If you wait a bit, 72 hours, 48 hours, basically everyone dies, red curves. So that's why in the recommendations that were subsequently done, based on this, it was recommended to give basically 1 gram very early on of corticosteroid bolus without thinking. But when you think about it, given the complexity of doing the diagnosis, given the complexity of getting the cardiac MRI done, the biopsy done, the biomarker trend done, I don't know how you can diagnose myocarditis in less than 24 hours back then when we knew pretty much nothing. So those cases were 2017, 2018. So this is what is there, but I cannot replicate that. So the current recommendation, I'm just going to show one. I'm going to show one, but the other institution, European Society of Cardiology, ESMO, have basically similar guideline like those one by ASCO. They all recommend to stop ICI when you have a suspicion, then to go on for high-dose corticosteroids. If it's not enough, go for higher dose of corticosteroids. And if it's not enough, you can try some other immunomodulator, basically initially based on case report stories. So we repeated this my ICI myocarditis evolution of mortality in VG-base with now the widespread use of corticosteroids. And you can see that mortality went down from 40% to 35%. So it's significant because we have a good amount of cases, but it's really not close to the 0% mortality shown. In our hands, in our center, for the first 40 consecutive definite ICI myocarditis patients that we have seen, again, 70 were sent to us as like, it is a myocarditis. We ruled out 30, and we kept only, 30, and we kept 40. So again, showing the complexity in the diagnosis. We gave everyone, following the guideline, 1 gram of corticosteroid as soon as they arrived to our hospital. And afterwards, if they were not responding plasmapheresis, we thought at that time that it was a good option. We think now it's not anymore. I will explain more. And then to subsequent treatment. And mortality in our hands with this regimen was 60% on the first 10 patients. Overall mortality 70% within a month. So we completely changed our paradigm, used some tailored immunosuppressions that would be more specific to the pathways activated upstream of ICI. So I will show in this scheme how it works. So it was abatacept and ruxolitinib, 2 drugs. I will explain more how they work afterwards. Very early on, with doses of abatacept adjusted on the biomarkers that we have set up to make sure abatacept was hitting completely the target, we stopped plasmapheresis and we screened everyone for respiratory muscle failure very actively, and also put some ventilation program in place very early on. And lastly, the grade 1 asymptomatic patient with no severity criteria, we just have not given anything. And with this strategy, on the 30 consecutive patient, we just had 1 death of myotox. It was a woman refusing to get the ventilation. She was diagnosed with a very severe respiratory muscle failure, but she didn't want to get the ventilation and died. And overall mortality was around 23%. Back then it was COVID time, 2 died of COVID and other cancer-related stuff. So those are the trends you can see of troponin T evolution when you have, as a function of the severity. So obviously the dead patients were red. You can see the highest level. And you can see also identify those green ones, which are basically grade 1 patient, no symptoms, coming in just for biomarker positive, and you can see it's going to stay positively abnormal for a while. But those patients we have not treated, and nothing happened. So there is also some patients that will tolerate and wait and watch strategy, because the immune system is auto-regulating itself, actually. So this is what I was just explaining. ICI basically will restore the T cell activity against the tumor, or when it is an autoreactive T cell against yourself. And you have CTLA4, PD-1, PD-L1, LAG3 that are players here. But you can see that upstream of all this cascade, there is CTLA4 agonists, which are abatacept and belatacept, which are basically going to downregulate the whole cascade upstream of the ICI used today. And how does it work? Abatacept and belatacept are going to target the monocyte, the antigen-presenting cells that is giving the command to the T cell below. and will basically tone down and impede the interaction between macrophages and T cells. And this works by working on CD80, CD86, so we want to make sure that this pathway is completely blocked. That's why we have put together this assay where we're going to monitor CD86 receptor occupancy and make sure that we're reaching over 80% of blockade to make sure that we're giving the right dose. So this is how it works. So the first case we described was this woman with lung cancer coming in with a troponin of 2000, which is basically 200 times upper reference limit, which is a lot. And she received initially those 1 gram equivalent that you can see of corticosteroids down, it's the blue lines. And as soon as we tap her, so this is something you very often observe in real cases, troponin went up from 2000 to 7000. So when you tap her, you will have a reactivation, a massive reactivation of the autoimmune disease, and then you'll go for 7,000. So at that time, we tried plasmapheresis, didn't work well. The patient started to have ventricular tachycardia, and this is where we started abatacept, which is the purple lines that you're not seeing well, but the purple lines are abatacept. And with this strategy, we were able to get the patient back to normal and be controlled. To further make sure that this strategy in this case report was potentially useful across the board, we collaborated with James Allison, which at that time had a mice model, CTLA-4 plus minus PD-1 minus minus. Basically, this mice model was designed to see which cancer will respond or not to immunotherapy. But in this model, mice were dying. As you can see, 50% were dying around 100 days because of myocarditis. So we did have a mice model. And the mice model was pretty good, same features, T cell, macrophages coming in, infiltrating the myocardium and killing it. Using this model, we tried abatacept, and it's the green line. The black line is control, and the red line is mice not treated. So those results were also very encouraging. But one important feature is that to be active, as you can see on the right side, it needed months, basically, to be fully reversing the cardiac immune infiltration. So ABA works, but with the doses we used here, didn't work very fast and took time. So again, if I go back to the first 10 patients we had, so I have already explained how important the fact that you understand there is a concomitant ICI myositis is important, because if you just take care of the heart, which we have done initially, and you miss the respiratory muscle failure, you'll get dead people. So the first 3 patients, the heart killed them. And then we were starting to understand better how it works. And this is when we had those respiratory muscle failure with diaphragm that we had patients afterwards go to autopsy, and we were able to identify that this was another big thing. So when you have severe patient, please, very important to check for respiratory muscle failure concomitantly. Why plasmapheresis is not working? You can see here PD-1 receptor occupancy blockade, and you can see that plasmapheresis will clear some of the ICI, nivolumab and ipilimumab here, but won't reverse the PD-1 blockade for months. So the doses used of ICI developed are way, way, way higher than those needed to block the system for months. So even if you get rid of 80%, 90% of the ICI in the blood initially, it's not enough to get the PD-1 receptor occupancy go back to normal. We need a fraction of what is used in clinical care to get PD-1 blocked. So the concept of CD86 receptor occupancy I just discussed before, basically because ABA is slow acting, because the doses we used were not good initially, like the indications for ABA at that time for rheumatoid arthritis are for diseases that are very slow acting. You have time, you can wait for a month for it to be active, which is not what we have when we have a severe myocarditis. So this is probably the first case where I said, we probably have the good mix. So again, this thymoma patient, 25 years old, coming in 1 dose of pembrolizumab, Few days later, troponin of initially 1,000 got in another center what you can see just below 1 gram, 1 gram, 1 gram of corticosteroids. And as we see in severe cases, as soon as you taper, went from 1,000 to 4,000 of troponin T. And what happened is the ejection fraction went from 60% normal to 0, ECMO. So this is where we're called. And we said, okay, at this stage, please stop using high-dose corticosteroid, just go down. He was tried on MMF before, but MMF take forever to act as well, so we stopped. And we say, let's combine abatacept and ruxolitinib and adjust abatacept dose to CD86 receptor occupancy. And as you can see, the first dose we gave of ABA is 20 milligram per kilo. It's approved 10 milligram per kilo. First dose, 20 milligram per kilo, you can see you do not reach an efficient CD86 receptor occupancy. So 3 days later, we reiterated the 20 milligram per kilo, and we're still around 60–70% of receptor occupancy. But the good news was that EF was starting to reverse, and that all the ventricular tachycardia that you can see up stopped. So we're pretty happy with those first results. But 7 days later, he restarted to do ventricular tachycardia. So we checked again CD86 receptor occupancy, and it was basically negative because of re-expression of CD86. So when you taper corticosteroids, it's going to re-express CD86, and that's how part of the mechanism how you'll get a very severe relapse. So again, we had to shoot him again 20 milligram per kilo of abatacept. So basically, he received in 10 days 60 milligram per kilo as compared to 10 milligram per kilo every 2 weeks that is recommended for rheumatoid arthritis. So 6 times more. And why ruxolitinib? Because ABA takes time to act, and we need a combination of treatment to be more efficient. We use ruxolitinib that is going to decrease CD86 receptor expression from inside. So we're blocking CD86 from outside with ABA and from inside with ruxolitinib. And ruxolitinib will have also JAK1/2 inhibitory pathways that are going to inactivate T cell more generally. So combining low-dose corticosteroids, ruxolitinib, and abatacept was basically our strategy that we have been using now for severe cases on over 150 patients, I would say. And our mortality is really, really close to 0. So the more you give ABA, the highest is the CD86 receptor occupancy. So this was just a small figure to explain that if you give 10 milligram per kilo, you're not going to get the same result as 20 or 25 milligram per kilo. And why we picked ruxolitinib was also part of this study we were doing in basic science, looking at ICI myocarditis mice and patient, and looking into JAK-STAT pathway, where we were able to identify that JAK2 was specifically upregulated in those mice and patients. So we wanted a JAK2 inhibitor. So in those first 40 patients, how was the outcome at the end of the day? If you had a myotox and you were dying of it, you would die quickly, 1 month, because again, when it happened quickly. And for those not dying of myotox, we were very interested to see that at 6 months, 75% of the patients were still alive, and 50% had not reached progression-free survival. Because one major question was, you're going to give all these drugs, so maybe you're going to destroy the ICI effect, and you'll get all patients dying very quickly of the cancer, which is not the case because it's all about regulation. So ICI is kind of a gas where you're going to activate the immune system, and ABA and drugs are going to be like brakes. And the question is just about how much braking you want to get in the exact zone when you want some activation, but not too much. So to further confirm this, we have done this trial that is now finished and the follow-up is done, and I can give you the result. There is 0% deaths at 3 months, overall deaths. So we tried in 21 patients, definite patient, confirmed patient, all severe, so 80% have ventricular tachycardia, 50% are ventilated. We tried 3 different regimens of abatacept combined to lower dose corticosteroids, 1 milligram per kilo per day, and ruxolitinib, 10, 20, 25 milligram per kilo. And in a nutshell, 20 milligram per kilo is the one where you're going to reach the lowest dose where you're going to reach your objective. So this is what we're using, 20 milligram per kilo, day 0, day 3 for severe, or day 5 if they're not too severe, and day 14. And additional dose eventually if it's not enough controlled. So at the end of the day, we have to keep in mind that we're treating those cancer patients, so we want them to receive the drug. So here there is a dilemma now. With patient having myocarditis, may kill them, but you want them to receive the drug. In this same thymoma patient, what was striking, one dose of pembrolizumab has created this catastrophic myocarditis, but at the same time have shrunken the tumor size by about half of the size. And so you can see here that as soon as you have a restoration of PD-1 expression, you will have a rebound of the tumor size. So this is the main question to come, is how we're going to be able to manage to get the patient get the drug, but at the same time mitigating the myocarditis thing. So here, a small, I would say, side project was, we had in the first 10 patients, 3 of them had thymic cancer, which basically as a cardiologist, I've never heard before seeing those cases. So I was like, what is the chance that thymic cancer, I'm getting so much? And so looking at the thymus function, basically it's clearing autoreactive T cell. Very early on, we said, okay, we should look into if it's not a major risk factor and if it's not key in the pathophysiology of this disease. So we looked at our own EHR at VGBase, the International Pharmacovigilance Database, at meta-analysis of clinical trial for myocarditis and myositis, and thymic cancer was a huge risk factor, 10 to 30 times increased risk. And interestingly, thymic cancer is specific to the myotox, as you can see on the right. It's going to be specifically associated with myasthenia gravis-like, myocarditis, myositis, and hepatitis because of the AST/ALT increased level. So it is specific to myositis, to myotox. And you can look into it more thoroughly. We checked then at the different patients. If they don't have thymoma, is the thymic structure different between cases and control? And it was also positive. And we now know, and there were like 2 Nature papers recently in the last 2 months, using the same strategy we used here with thymus scoring, to look at the effects and efficacy in ICI patients, and they were able to show that if your thymus is healthy, you'll get a better overall survival in general population and in patient on ICI. And if you don't have a thymus that is healthy, even if you're old, you'll have a bad outcome. So thymus, we were thinking, was just useful in childhood. It's not. It's still working. It's still important in adulthood. And so another surrogate of thymic dysfunction would be also to look at acetylcholine receptor autoantibody production. That's why we also added this last biological piece. And looking at patient with myocarditis and patient without myocarditis on ICI in our hands and international replication cohorts that we collaborated with, we're able to see that acetylcholine receptor positivity was around 20-25% in cases as compared to 4% in the general cancer population on ICI. And it was also carrying a prognostic value, this acetylcholine receptor autoantibody. So this brings me back to the myasthenia gravis phenotype. Acetylcholine receptor autoantibody, when it was positive, was present before ICI start. So it's probably just capturing this thymic disimmunity and dysregulation, and is another biomarker of this whole autoimmune messed up system as compared to some targets that you should treat and that is produced specifically by ICI. So more recent paper, we used the French national system, health system. So here there is around 68 million patients. On them, there was 172,000 put on ICI. You can see here the different cancer type and ICI regimen. And the incidence of myotox, so including myocarditis and myositis, was around 0.7 to 0.9%, depending on the codes we used, combination, broad and narrow codes. And again, thymic cancer was the one sky high alone, as you can see, with more than 10% of incidence. So giving ICI in a patient with some timing trouble before starting is tricky. And again, we're able to replicate that combination of ICI and TPD1 plus anti-CTLA-4 is carrying an increased risk. So what is the impact if you have a myotox while you're treated on ICI? You can see here it's not a good news. At 3 months, if you have a myotox, your survival rate is around 40% as compared to 80% on ICI without myotox. So in this French system, claim system, having a myotox was basically increasing your risk of dying of 4 to 5 times. And so risk factor for ICI myotoxicity from this study, combination therapy, possibly combination with anti-angiogenic, it's not stable, age, elderly age, melanoma and the skin cancer more than lung, kidney more than lung, active thymoma, as we were discussing, very high, history of timing disorder, history of myasthenia gravis, history of rheumatoid arthritis, and morbid obesity are also risk factor. So which brings me back again to the myasthenia. You may have a pre-existing myasthenia gravis, which is going to be a risk factor to develop myotox. So in rare cases where you have pre-existing myasthenia gravis, eventually you'll have to tease out what is a major contribution to the phenotype you're observing, and if you need or not to give IGIV or some specific myasthenia gravis treatment. And so of what do we die when we have a myotox? So it's on the right side, heart failure, arrhythmia, and respiratory muscle failure. So basically we checked that with this claim system, we were able to find what we know about the disease, kind of positive control, which we were able to see. And of course, metastatic disease and age are not good prognostic factor. So I would like to thank, of course, all the people here in the microdialysis registry, and I hope to get a bit more of the Canadian representation here. And those are the last studies using this registry again. So we were able to build up a score to stratify patients who will need or not to be treated aggressively. So here in this study, including corticosteroid, as you can see in the bottom, and all the other prognostic factor, you can see that corticosteroid is not carrying any more association. But what is important, again, active thymoma, early time to onset, Sokolov-Lyon voltage, so ECG QRS decrease, LVEF ejection fraction below 50%, and the magnitude of troponin increase. So the higher is your troponin, the worst is the situation. So with the point system, active thymoma +2, cardiovascular symptoms, so patient with symptom +1, low voltage +1, LVEF below 50% +1, 20 to 200 times upper reference limit of troponin +1, 200 to 1000 +2, over 2000 +3. But what is important here, 0 or 1 to 20, 0. So patient coming in with troponin below 20 times upper reference limit were not associated with worse outcome. So when we adjust on everything, and those are the risk score 0 population, a patient without symptoms, not thymoma, ECG without microvoltage, and troponin below 20 upper reference limit repeated over 3 days, may not need anything. And this is something we have replicated in our hands. So from April 23 to February 24, we have seen 35 confirmed patients, of which 20% were basically score 0 patient. We have done nothing with them, and you see the outcome is super flat. It's a green one. And we validated also this score in the retrospective Mass General Brigham validation cohort, and it was also similarly working. So this, I guess, is my last slide, or my last concept, is re-challenge. So now that we may have a cure for managing the severe cases, what about re-challenging patient? So this is there is something we're discovering. It's a new book chapter, I would say. And if we go back to our own experience on 308 patients we have seen with suspected myotox, 138 had the confirmed myotox after a first line. As a note, 5 of them did not have myotox after a first line of immunotherapy, but developed it after a second line. So also saying that if you don't have anything in the first line doesn't mean you will never have anything else in the second line. But 138 had after a first line. Of them, we have continued immunotherapy on 7 and rechallenge 7. What is the difference between continuation and rechallenge? Continuation is below 3 months after the last dose of ICI, and rechallenge over 3 months after the last dose. The one we continued is basically some grade 1-2 patients that you can see in panel C. We didn't thought initially they were maybe myocarditis, but we were wrong. It took us time to get the peripheral muscle biopsy and other stuff that confirmed at the end that it was a myotox. But as you can see, it went pretty well for them. They stayed grade 1-2, and most of them had, none of them had a progression disease, as you can see, but most of them were basically neoadjuvant setting. On B and D, you can see patient with rechallenge. So we have also rechallenge patient very severe, grade 4 or grade 3, as you can see with arrhythmia and respiratory muscle failure. Because we were 4 years afterwards, they had exhausted all the different anti-cancer therapy and the patient were willing to retry. So we have done it in 7 patients. The only problem I would say is that the cancer response was not as good because we waited a lot of time. So you can see that small squares are the performance status. So initially in the first line, they were all basically performance status 0 or 1. And when we rechallenged them, most of them were 2+ because we were waiting so long before doing it that didn't get, basically they didn't have a recurrence or a clinical recurrence, but they didn't have a cancer efficacy neither. It's only 7 patients. But one of them was very nice. It's a patient with grade 4 initially who basically recurred grade 3, but after 1 dose he had complete response. 4 years later, after 1 dose, he re-had complete response, but with the grade 3s that we have managed with Abarox corticosteroids very early on. And we're able, and now he's like 7 years after the first episode. So here is the team who are helping like every day on all this stuff. So I would like to thank them as well. I'm done.
Bravo.